From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. Concussion, or mild acute traumatic brain injury, is incredibly common. 1 in 5 adolescents report having suffered a concussion at some point in their lifetime, and an estimated 1 in 5 players of contact sports suffer a concussion each season. Sports neurologists are rare enough that most people suffering concussions never see one, and general neurologists aren't always well trained to treat this condition, especially as the science of concussion is advancing. Our guest today, Dr. Jose Posas, is a sports neurologist and residency program director at Ochsner Health in New Orleans. He spoke to ANA producer Dr. Mandy Jagolino-Cole about recent findings in concussion research and how we can apply that research at the bedside. Here's Mandy.
Welcome, Jose.
Thank you for having me.
Well, let's get started. Concussion is incredibly common, but not all neurologists feel confident managing it. Can you tell me 3 things you wish neurologists knew about the clinical management of concussion?
Yeah, absolutely. So there's the return to play, but really encouched in that is return to learn, especially for adolescent population. For our adult population, return to work or return to productive living, right? It's quality of life. So that's part 1. Part 2 is how to deal with the very vague complaint of dizziness after concussion. Is there a vestibular component? Is there an oculomotor component? And the third part is, not all concussions are sports-related concussions. There are special populations that we have to consider, including our veteran population and survivors of domestic abuse.
There's a lot going on. So I guess let's start with return to play or return to learn or return to work, as you mentioned. What does the latest research show us?
Sure. There's the CARES Consortium research, which actually looked at collegiate age athletes from 2018 backwards to 2014, as well as cadets in the military schools that we have in this country. And looking at that, the research shows that at about 30 days, 90% of people get better. They looked out at 60 days, and another about 75% of people got better of the miserable 10% that were not better in the 90 days. And then of those people at the long term, the 3 months out, about 75% all got better. So there's a very small minority of people that go on having symptoms past 3 months. So understanding that this is a physiologic process, it's going to take time to improve and correct the metabolic mismatch that happens after concussion. That's important. And understanding that metabolic correction typically happens within the first few weeks after concussion, certainly by the 30 days where 90% of people get better. Absolutely. Thinking about writing accommodations for them to return to school and return to work, I think, is critically important. If you see somebody 2 days after their concussion and they're still heavily symptomatic, sure, yeah, you've had a concussion, but I will also write them, hey, when you return to school, let's allow you to wear sunglasses and a hat. Let's make sure that you can get notes that are either pre-printed or from a note taker. Let's make sure that you can leave your classroom to go to the nurse's office if you're too tired. Let's make sure that if the students transition in the hallway, can we get the student who is concussed to leave class a little bit early to get to the next class to avoid the very loud hallway and transition scene that can happen in middle schools and high schools. And then for return to work, if people have sensitivity to light and artificial light, can we get them in an office or a place with reduced light? Are they able to work from home? If it's manual labor, is there sedentary work that they can do before they get back to having to lift heavy objects? Or especially if somebody works, for example, I'll give one here. We are next to the Mississippi River. We have people who are dock workers or work on pipes on the water, making sure if they're dizzy, especially in the first couple of weeks after concussion, let's do other tasks at work rather than walking on 1/4-inch pipe over a rushing river. Things that you wouldn't necessarily think of because it's so sort of base level and practical are things that I've written before, just because it's a dialogue. Hey, what do you do for work? What does that actually entail? And then making sure that you think through the process of how do we make sure you don't become injured moving forward? And then after that, how do we get you back healthily living? How do we get you back into exercise? What do you love to do? Do you love to bike on the weekends? Do you love to lift weights? Are you an amateur power lifter? Do you want to become the star of your soccer team again like you were before? We have to get people to progress through that. I have some patients who are so alpha and so bodacious that I have to put the reins on them and say, hey, listen, let's not go for a 25-mile bike ride on your first day back. Let's start with like a little short 1 mile and see how you do and titrate symptoms as they're returning to play. So when I have patients like that who are concussed that are so alpha, I joke and say, hey, my biggest job here is to stop you from delaying your own recovery. And they have a little bit more buy-in with me when I talk to them like that.
So I have to ask, we learned in residency about the Colorado Medical Society guidelines. Are we still using this grading system? Any comments on if this is applicable to our concussion population?
That's a great question. There have been leaps and bounds since those kind of guidelines, and also there were guidelines not only from the Colorado grading system, which is 1, 2, and 3, knocked out for 5 minutes or less, knocked out for 5 minutes or more. There have been findings over the last decade that show there's no correlation between outcome and that grading system. So far and wide, we don't really look at that grading system as predicting who's going to go into that miserable 10% of people who are symptomatic still after that 30-day period, or the 25% of those miserable 10% who at the 90-day period are still symptomatic.
So is there a new way to predict who will go on to have long-term symptoms?
That's a fantastic question. From the Concussion in Sport group, the international consensus statement from the experts, the last one came out of 2017 in Berlin. They just met in Amsterdam in the fall. And so the next Concussion in Sport group, the international consensus statement, will be coming out likely this year. So I wait with bated breath to see that. But even from the 2017 statement, there were thoughts that the pre-existing diagnoses or comorbidities, such as having a history of migraine, having anxiety, having depression, having bipolar, having ADHD, those are things to look out for. Other things that may be prognostically challenging for patients to recover after would also be significant loss of consciousness, but there's not necessarily a timestamp on that. And then also amnesia of the time of the events, meaning the patients cannot encode what exactly happened. It's a disconnection syndrome right there at the time of injury. These are things that are extremely important to know moving into this world.
Fascinating, and it sounds like there's more to come. You mentioned also dizziness after concussion. What causes this dizziness, and how should we be managing it?
That's an excellent question. This is a tough nut to crack. For those folks that are having symptoms, if they're starting to have symptoms that linger past 3 weeks or 4 weeks, and you want to try to help them get better, thinking about what is causing their dizziness is important. So thinking about vestibular features. In the office, can a general neurologist do a Dix-Hallpike? Can they do a Romberg? Sure. There is another diagnostic test called the Balance Error Scoring System, which is used more in the sports world. There are issues with inter-rater reliability, et cetera. However, finding out if somebody has a problem from a sensitivity standpoint is better to then say, okay, you need vestibular rehab. Typically, in most states, it's with physical therapy. However, there are some states that occupational therapy can do it as well. That brings up another idea of, well, what if somebody has a visual trigger for their dizziness, complicated visual backgrounds from using screens, using Excel sheets, for example, in a stats class? That might be very difficult for your adolescent or college-age athlete to return from. So having ocular motor rehab for that with occupational therapy is what I do in my practice. The confounder here, of course, is now there's more data. Dr. Pearson at CHOP is looking at data with regards to dysautonomia. She did a really well done study and presentation in the fall last year. There are some times where people say, oh, I'm dizzy, and up to 30% of them could have dysautonomia, which is another difficult thing to try to manage. So it expands the level of complexity here. But luckily, some of the work coming out of Buffalo with Dr. Letty shows that exercise can help combat some of the dysautonomia. Sub-threshold exercise, as they return, if they get too symptomatic, pause it, but otherwise they are able to return to play faster, because these are athletes we're looking at in this particular population.
Yeah, dizziness is hard already to manage, diagnose the cause and manage. So it sounds like this adds another dimension. Thank you so much. The third pearl you mentioned was that concussion is common outside of sports. You mentioned veterans, cadets, also victims of domestic violence or assault, perhaps. Do the findings from sports concussion research translate to these other populations?
Yeah, so the question of, is this data generalizable, is one that weighs heavy on my mind, especially when we think about sports concussion. So the question ends up being, what is different about sports concussion from a military concussion, right? A blast injury. And we know from a fundamental physiologic standpoint that the vector and point of force is very different when someone gets blown up by an IED or has their Humvee roll over on them versus if someone gets knocked over while they're the star running back on the team. So the issue here ends up being trying to adjust to that population and understand that the body armor, for example, we know this from football, even the old leatherhead helmets prevent skull fracture, but they actually cause a stiff surrounding case to be around the brain, which can transfer damage to the soft tissue. So while we're glad for the body armor for our troops and glad for the body armor, the helmets that they wear, concussion ends up being the signature injury coming out of many of our Gulf War and Afghanistan interactions. So that is something that is well known within the VA literature.
And also for victims of domestic violence or assault, where are we
Yes.
on that in terms of management?
Yes, so for victims of domestic violence and assault, thank you for bringing that population up. It's very important to realize that many of them, and I'm quoting data from Dr. Jelinis Zeman at Barrow Institute, their data shows that domestic violence sufferers don't even know they've had a concussion the first time they're injured. And when they've been asked in the domestic violence intake information, these are the symptoms of concussion. This is what to look for. Do you think you've ever had a concussion before? An astounding 87% of them answer that yes, they have likely had a concussion before. And up to 80% of them say, yeah, I've had multiple.
So there's a lot of things to consider with, epidemiology and mechanism of injury. Thank you for sharing all of this. Concussion, especially repeated concussion, can cause lasting effects. These we've seen can include headache, cognitive and behavioral changes, mental health issues, and even Parkinsonian symptoms. When should a general neurologist refer a patient with concussion to a neurologic subspecialist? And what types of subspecialists might offer expertise in these cases?
Absolutely. This is a great question. So I think the guiding principle here is that many people with concussion, especially acutely, get better relatively quickly. If someone is starting to linger past a month, then further thoughts about rehabilitation and referral to appropriate rehabilitation, such as vestibular rehabilitation, oculomotor rehabilitation, or guided return with sub-threshold exercise with a personal trainer, for example, might be warranted, especially if somebody is complaining of things like dizziness. Is that referral to a neuro-otologist helpful? If somebody is having problems with a complex visual background, is it helpful to have someone referred to a neuro-ophthalmologist, for example? If somebody is having significant post-traumatic headache, there is some burgeoning idea that nerve blocks, for example, in addition to the oral medication route, can be very helpful when applied at appropriate stages. If a general neurologist is not facile with the more advanced headache techniques or procedures, then certainly trying to partner with someone in their area would be reasonable. Other things that can happen, especially for somebody who is a little bit further along in their life and has Parkinson's, there is some data from the VA that suggests that Parkinson's might have a higher risk in patients who have had traumatic brain injury in the past, but this is all comers. This is not concussion specifically. So finding someone who has a background in movement disorders or some facility or expertise in Parkinson's would be an appropriate referral to a subspecialist. And of course, the other thing, mental health outcomes are important. So partnering with psychiatrists and or psychologists and talk therapists within your community may be very helpful to address some of these lingering issues.
It sounds like it's a lot of multidisciplinary or interdisciplinary management, and so that's good for us to know. With the risk of concussion, and this may be a bit controversial, many have called for an end to football or other contact sports with high rates of concussion. What's your take on this concern, if you don't mind my asking?
This is a very complicated question, and I will try to answer without any inflammatory or upsetting news here. There is a economic and socioeconomic and healthcare discrepancy between different populations in the United States. That's relatively easy to understand. There are many people for whom contact sports, unfortunately, is the way for them to get up and out of their socioeconomic rut that they're in. There are ways that high school students get scholarships to college students get into professional sports leagues, and then once they're there, they're able to pull family members and loved ones out of lower socioeconomic standing. There are numerous examples of people that have gone on to illustrious careers and then pulled folks up with them, LeBron James being a very famous one. Even folks who have had unfortunate deaths that were thought to be potentially linked to things like CTE. Junior Seau, for example, is another pro athlete who is very involved with his community. That all being said, I think it's important for us to understand that as neurologists, I believe, and this may be somewhat heretical, the idea here is risk mitigation. We live in the real world. Risk elimination is not there. I think the best idea here, rather than to burn out as a neurologist, my approach has been, let's engage, let's educate, let's try to reduce risk, so that way I feel satisfied instead of trying to fight against, I have to eliminate all risk. From a personal standpoint, I would say, and this is me taking off the neurologist hat, but I'm putting on my parent hat. I have 2 young girls. They play soccer, they're into musical theater, et cetera, et cetera. I wouldn't stop them from playing what has thought to be the highest rate of concussion generation in a female sports section, which is soccer. I think it's a wonderful sport, but making sure that they know what a concussion feels like and making sure their coaches are educated on this is something that I believe in strongly.
Yeah, I think athletes have a lot to gain from the physical activity, getting active, being active, and so definitely understand your perspective on that. Thank you for sharing. And then, where do you see the biggest gaps in care and concussion management right now?
I think it's a team sport. I think part of the care and concussion management needs to be done collaboratively. We know that there are a few neurologists in this country. There are not enough for the entire population, and there are less sports neurologists. So if we can all take a part and try to help as best we can and partner with our sports medicine primary care physicians or orthopedic concussion specialists and lend a hand when we can so that our patient populations and communities are doing well, I think that's the best way to move forward. Partnering with mental health providers and partnering with rehab as a neurologist in practice, I think will also shed light on the path forward.
What do you think is the next big thing in concussion research? What should we be watching out for?
I wish I knew more about some of the biomarkers, not only from a blood-brain barrier standpoint, meaning serum tests, for example. There have been a few. There's actually one that got FDA approval for concussion, but if you actually read the primary scientific article that's attached to it, it's to detect if someone in the ER needs a CAT scan for a brain bleed or a contusion or a skull fracture. And the last time I checked, none of those 3 diagnoses are actually concussion, because once you have imaging changes, that automatically moves it from a mild traumatic brain injury to a moderate or even severe traumatic brain injury. So with regards to clinical return to play based on biomarkers, either serum or imaging at this point, I don't have that yet. There are various academic institutions and commercial entities that have significant interest. This is the holy grail for everybody. Once they crack that, I mean, I think, game over. But for now, those end up being very tricky questions. And this is where sort of the art of medicine, the art of neurology comes in.
Well, it sounds like we'll get there. It's great that we have this emerging field, and it sounds like there's a lot going on. So thank you for sharing these updates and where we are with concussion research and clinical management. And it was a pleasure speaking with you.
It is a pleasure of mine, and I thank you for taking the time to listen to me talk about this very near and dear subject to me.
That was Dr. Jose Posas, sports neurologist and residency program director at Ochsner Health in New Orleans, speaking to Dr. Mandy Jagolino-Cole of the University of Texas Health Science Center at Houston. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Megan Ritchie. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Mandy Jagolino-Cole and me with help from Jen Hurley. You can listen to past episodes of the show and access all of the ANA's educational programs at myana.org. That's it for ANA Investigates. See you next month.